Hi, it's Dr. Reber. I am here to talk to you about AIVR. So we're going to see if we can get this going here. So we're going to do a quick talk just about this one dysrhythmia, AIVR. And here on the front, I have some pictures of a coronary artery that has some plaques, and this person is getting a PCI, a percutaneous intervention, which the most common thing we mean when we say PCI or percutaneous intervention is somebody's getting an angioplasty and a stent placement. And then after this, all this new arterial blood starts to rush in and they get reperfusion of that artery. And one of the ways that we know that a coronary artery has been successfully reperfused is they start to get this dysrhythmia, which is AIVR. So it's a little bit different, AIVR, because we consider it a reperfusion dysrhythmia. All right, so it's accelerated idioventricular rhythm. And IVR, which we could also call ventricular escape rhythm, it is an escape rhythm. But AIVR is a little bit of its own unique thing because who gets it? We consider this a reperfusion dysrhythmia. So we see people getting runs of AIVR after they've gone to cath lab and had their angioplasty and their stent placement or some other revascularization procedures. They might have just had bypass surgery like a CABG, cardiac artery bypass surgery, or they might have even gotten and have like a clot removed. So that's something else they could do in cath lab. And then a bunch of blood comes rushing back into these arteries. These are people who will get these runs or they'll have an incidence of AIVR. And in fact, we kind of think of it as almost being a good thing because it means that a bunch of blood has rushed in and hit that area of stunned arteries and there is reperfusion happening. But it is a dysrhythmia, but we almost see it as a positive sometimes because it means there's blood flow getting downstream to those areas that was not getting blood. So what could you expect for somebody who's having some AIVR? Well, because it's accelerated, the heart rate is accelerated. Usually ventricular escape rhythm or IVR is really slow, like less than 40 beats per minute. Those people feel terrible. IVR is not really life-sustaining, but AIVR has a faster rate, and usually it's like pretty fast, maybe between like at least 70 and 100, maybe closer to 100 a lot of times. So because it's accelerated and their pulse rate is pretty good, a lot of times they're hemodynamically stable while they're having this. Now, they could have some symptoms, like they might feel some heart palpitations. These are pretty big, wide QRSs. Sometimes you feel a little thump thump, or they might have some mild anxiety or mild shortness of breath, but they are not usually unstable or having like a rapid response type situation. Usually stable, hemodynamically stable when they're having their runs of AIVR. So what will we do for treatment? Okay, well, when people are stable, we don't really do a lot of stuff to them. We just watch them. So it can occur suddenly, but it tends to be self-limiting. This is a really important thing to know. So as the patient recovers from the treatment they just had in the cath lab, or as they recover from their open heart surgery, the AIVR tends to go away. So we just support them as we normally would and recover them from whatever it is that they just had. And we support any symptoms. So if they got a little short of breath, we give them a little oxygen. If they're highly symptomatic, then of course we're going to support them and treat their symptoms. And any treatment we do is focused on treating the underlying problem, not really the dysrhythmia. Now, there's one really important thing I want you to know. We typically do not cardiovert this rhythm and try to wipe it out. We do not typically give amiodarone to this rhythm because that's an antidysrhythmic to try to convert somebody out of a rhythm or suppress a rhythm. This is an escape rhythm, not an ectopy. So cardioversions and antidysrhythmic drugs, those are strategies to get rid of a rhythm when you think sinus rhythm is underneath and being smothered. But there is no sinus rhythm underneath because this is IVR. This is a form of an escape rhythm, technically. So if you wipe it out, there's not sinus rhythm underneath. So if you were to give them amiodarone and suppress this, there's a risk that there's just asystole underneath this. So we do not typically cardiovert or give amiodarone to AIVR. That's an important thing to know. All right, key concept here. AIVR is an escape rhythm, not ectopy. Now, it is a little bit weird because it kind of acts in between. It acts sort of like an escape rhythm, but it's a little faster like an ectopy. But technically, it's an escape rhythm, just a faster version of ventricular escape rhythm. Ectopies we want to get rid of. But escape rhythms, we appreciate escape rhythms. We're so glad you're here. But we still ask, why are you having them? What's your underlying problem? How is the patient feeling? And we support them. And remember, if somebody's in escape rhythm and their rate is too slow, we usually back them up with a pacemaker, right? So we could do that for AIVR. Let's say somebody was in, now this is not as common, but let's say somebody was in IVR, just idioventricular rhythm or ventricular escape rhythm. You can call it either one. And that should be less than 40 beats per minute. That's super slow. These people are coding, they're code blue, they feel terrible. And your body's like, oh, this is not enough blood pressure. And it squirted out some adrenaline and speeded that up to 45 beats per minute. Okay, well, technically, that's accelerated idioventricular rhythm, right? Because it's above 40. That's technically AIVR, but the patient's still terrible and coding and awful. We would put him on a pacemaker. We can't wipe it out with amiodarone. It's an escape rhythm. If you get rid of that, there isn't any sinus rhythm underneath there, right? There's nothing there. So we can't cardiovert them out. It's not an ectopy. If you wipe it out, there isn't anything there that's better that's going to come forward. So you can't wipe it out. You have to support. If the rate was very slow, we could support it. But usually AIVR is very accelerated. So it doesn't usually need that. We do not want to eliminate it because sinus rhythm is not underneath there. All right, let's look at recognition. So here's 3 different things to look at. Here's we got normal sinus rhythm. Here's just regular IVR. We're going to recognize it because the QRSs are going to be wide and it's going to look ventricular, meaning the QRS is 0.12 or greater, but probably wider than that even, probably 0.14 or more. Then if the QRS is mostly up, the T wave is going to be down. And if the QRS is mostly down, the T wave is going to be up. That's very ventricular looking. And with normal IVR, the rate is really slow, like less than 40. And in fact, a lot of times in IVR, the QRS is so wide and unorganized, it doesn't even produce a pulse. So the person might just be laying there pulseless and mostly dead. IVR is almost always a code blue situation. It can a lot of times be an agonal rhythm for people. So don't listen to any stuff your book's trying to put over on you. Nobody's just sitting there okay in IVR. It's a terrible rhythm. So that's IVR, less than 40. Now, if IVR was accelerated, that's AIVR. But so anything that looks like IVR, but it's between 40 and 100, well, that's AIVR. But that's not really the full story for just sight reading AIVR. It's its own unique rhythm. It's just not a slightly speeded up IVR. It's something unique unto itself. It's usually closer to 100. Like it likes to go between 70 and 100 or 80 and 100. And in fact, I know this is going to be really weird, but every now and then it goes a little bit over 100. In fact, there's this gray zone between like 100 and 110. And you're like, wait, that would be ventricular looking and tachycardia. Isn't that like Vtach? Between 100 and 110, this is getting real hard to tell if it's AIVR or if it's Vtach, because they're both ventricular and they're right around 100, but Vtach doesn't like to go that slow, And that's a little bit fast for AIVR, and they're both ventricular and they're looking so much the same. This is tricky. So that's really a little bit above our level right here, but I'm just letting you know it's out there. Okay, so let's try to look at some other things. What else is weird about AIVR? Okay, well, let me tell you about it. For one thing, the QRSs suddenly get really big, like now we already know they get wide, right? But they get very, very tall if they're going up and very, very long if they're hanging down. So I was thinking about them looking like sharp knives stabbing up or long icicles hanging down. I mean really long, like noticeably long. If you're doing a 12 lead or a dual channel recording, a lot of times they're so long that they're overlapping with other leads. Or if it's the kind of recording device that doesn't allow overlapping, they'll be squared off at the ends because they're too long to fit into their channels anymore. So you were going along with regular beats, and now everything is so long they're all on top of each other. That's a look that is common to AIVR. Another thing is sometimes AIVR is paroxysmal. I mean, that's almost like a ectopy type of thing. But this is not ectopy. This is escape rhythm. But it's a reperfusion dysrhythmia. It's about blood hitting this ischemic intimal blood vessel, layer of the blood vessel. So there is a cause and effect that's occurring. It's really not ectopy, but it can suddenly happen in little runs. It's usually self-limiting and it will just stop without an intervention. So that's a little bit weird for an escape rhythm. It is very easy to mistake AIVR for Vtach. So if you have something that looks like Vtach, but it's too slow, so you'll say, oh my gosh, my patient's in Vtach. But then when you look at the rate, it's only in the 80s. Well, it can't be Vtach if it's not even tachycardia. This is probably AIVR. And also the patient's like pretty stable. They're not having any chest pain, and it's not even tachycardia. So it can't be Vtach. This is AIVR. Now, did they just get out of cath lab and having their angioplasty and stent placement? Well, then we're actually expecting AIVR. So if it was Vtach, if people are having Vtach, we want to get rid of Vtach. It's ectopy. If it's AIVR, that's an escape rhythm and it's expected for reperfusion. We do not want to get rid of it because if we wiped it out, there's not sinus rhythm underneath. So how are we going to tell the difference? The rate. This is the number one way that we tell the difference. Also the shape. We have these long knives stabbing up or icicles hanging down. And the etiology, like what do we know about the patient? All right, let's look at some examples. So we got some multi-channel leaves. On this one, we got some big knives stabbing up. And you can see they're so big that this one's starting to overlap with the channel ahead of it. And we can take a quick look at the rate. Now, a real quick way that you can estimate rate is how many big boxes stuff is apart. So just if you were to add up the boxes and like how much every little box is worth, if QRSs are 3 big boxes apart, we can count down like this. So that's 100. So let's try to find one that's on a line here. So we can find something that's close to being on a line. This one's pretty close. So when stuff is 1 big box apart, if the QRSs are coming 1 big box, like 1 QRS every big box, the rate would be 300. Hopefully that doesn't happen. If stuff is 2 big boxes apart, so it goes 300, the next one is 150. Stuff that is 2 big boxes apart is 150. Vtach loves to go at 150, where every QRS is about 2 big boxes apart from each other. So 300, 150, 3 big boxes apart is around 100. So if stuff is about 3 big boxes apart, the heart rate is around 100. So this, where they're having these big, tall QRSs, they're about 3 big boxes apart, so we know the heart rate's around 300. There are no P waves. This is AIVR. Let's look over at this one. Now, we got some icicles hanging down, and you can see they're getting squared off at the bottom. They would be even pointier, but that's where the channel blocks them off. And the rate, let's see if we can find one that's kind of on a line, like right here, 300, 150, that would be 100. It's a little bit less than that. We're in the 90s and no P waves. Now, it can't be Vtach because it's not even tachycardia. It's in the 90s. That is AIVR. Oops. Okay, let's take a look here. So we got knives stabbing up if you're looking in the V leads. So over here at V1, V2, and V3, and V4, it's knives stabbing up, not so much over here in the inferior leads, 2, 3, and AVF. And we learn more about these different leads. We do 12 lead day. But some of the leads, it looks like knives stabbing up, especially here in V2, V3, and V4. It looks a lot like it might be Vtach, but it's not fast enough. So there are no P waves. And you might be like, what about this one spot where there's a P wave? Don't worry about one spot, right? Don't worry about one spot. Just overall, it's wide and bizarre, and there are no consistent P waves. And then the rate, let's find one that's kind of on a line. 300, you can go either direction, by the way. 300, 150, 100, and then the next box, if you're wondering, will be 75. So it's between 75 and 100. It's probably going to be around 80. I counted 19 little boxes apart. That's a heart rate of 79. And if they're 4 big boxes apart, that's a heart rate of 75, and it was just less than that, so it's probably around heart rate of 80. So it can't be Vtach. They're only around 80. That's AIVR. Okay, let's look. We only have 3 heartbeats right here, but they're big and wide with the QRS up and the T wave down. Definitely ventricular looking, no P waves. This looks like IVR if it was less than 40 beats per minute. But how fast is it? Well, if we see how far apart they are, they're going to be about 1, 2, that's 3 little boxes. That would be a rate of 100. It's definitely less than 100 beats per minute. So it's too slow. It's not even tachycardia. It's too slow to be Vtach, but it's too fast to be IVR, or ventricular escape rhythm. This is AIVR. We can tell with just 3 complexes. It's in between that heart rate range. Okay, let's take a look at this one. You can pause it for a second if you want to look at it. Look at the shapes. Are there any P waves? Then find an R wave that's kind of on a bold line where big box starts and see if you can estimate the heart rate and decide if it's Vtach or AIVR. Okay, so I'm looking at this one. It's right on the line. And here's 300, 150, 100, and that would be 75. So this is putting this about in the 80s. So they're somewhere in the heart rate range of the 80s. That's AIVR. Not fast enough to be Vtach. Now let's look at this one. Wide and ventricular looking. They're only about 7 little boxes apart from one to the other. So, I mean, here's one that's close, and you can see the next one's not even 2 boxes away. This is a heart rate of about 215. That's Vtach. That's like a very fast Vtach. It's like Vtach loves to go at 150. This is even way faster than that. So it cannot be AIVR. It's too fast for AIVR. This one could be knife stabbing up. It's not that tall though. It does have a wide QRS, no Ps. Let's look at the rate. So here's one right on a line. We got 300, 150, 100. It's definitely above 100. It's getting close to the 150 mark. Vtach loves to go about 150. That's Vtach. It's too fast for AIVR. What do we think about this one? Okay, it's definitely looking ventricular. We got no Ps. Let's find one that's on a line-ish. This one's pretty close. 300, 150, 100. 75. So it's between 75 and 100 for the heart rate. That's AIVR. And then let's look over here. We only have a few beats. This is a real patient, obviously not computer generated. And the look of this is very AIVR. You can see out there really long icicles hanging down. You can see from the channel above, it's overlapping with this channel. The rate is 300, 150, 100, right around 100. This is looking very AIVR. All right, that is it for me. Thank you so much. If you have any questions, just reach out.